Hello, and welcome to this brief lecture over myofascial pain with a focus on trigger points. So before I get too far describing all the causes and the treatments for myofascial pain, or specifically trigger points, I would like to explain the physiological aspects of the formation of these tender areas within our fascia. So to begin, let's look at the simple model of these two pictures of the muscle fascicle. So in the first picture, and then the second picture to the right is actually a zoomed in view of the first picture. So here there are a few muscle fibers, and each of these fibers are innervated by a motor neuron. And then surrounding these fibers are arterioles that supply these fibers with oxygen and blood. And then the blood also contains other nutrients that are necessary for the fibers to contract. As well as having the fiber and the motor neuron over top of it, on the fiber underneath the motor neuron are little tiny receptors called nociceptors. They innervate the fascicle, which is sensitive to the presence of oxygen, ATP, and other chemicals, which can be carried through the blood. So each motor neuron sends a nerve impulse to the neuron motor end plate. So as you can see from the picture, the neuron is descending upon the area of the fiber, and the end of that neuron is what we consider the motor neuron end plate, or the motor end plate, which is on the surface of the fiber. So when the motor neuron sends the nerve impulse down through the end plates, it will pass through the end plate to the fiber, and this is what we call an action potential. So when an action potential reaches the end of the plate, acetylcholine is released. So now that you've kind of received a little bit of the background of a little bit of background info on the physiological area, now we want to know how trigger points can actually be formed. So each fiber surface contains several other types of receptors, not nociceptors, but other receptors, and I have that circled in black on that picture that you see. And these receptors bind with acetylcholine. So remember I said acetylcholine is released after the action potential, and it binds to these receptors that are on the fiber area itself. And this causes depolarization. And eventually there's many small details that occur, but depolarization, if large enough, will cause a fiber contraction, or the sarcomeres to overlap each other, and if there's enough fiber contractions, then the muscle area itself will be able to contract. However, say that a muscle is injured or damaged, or it goes through a sustained or repetitive contraction. The muscle damage or contraction will compress the local blood vessels, which in turn will decrease oxygen. Remember, oxygen is brought through the blood vessels. It will decrease oxygen to that area. And so naturally, reduced oxygen combined with the metabolic demand of the stressed tissue will deplete ATP. And if you've learned anything about ATP, it is what we use, and it is kind of like an energy source for cells in order to do their jobs. So ATP is depleted, and one of ATP's functions is that it controls acetylcholine, which has been released from the motor end plate and binding to the receptors of the actual fiber. So when ATP is depleted and it no longer is able to control how acetylcholine is released, then acetylcholine starts being released in increased but sporadic small amounts. So usually there's a large amount of acetylcholine that is released during depolarization, or before depolarization, but this time, now that we are lacking the energy source, only small bursts of acetylcholine are able to be released. So these small bursts are producing numerous small end plate potentials. So not your large action potential, but just small end plate potentials. And then these end plate potentials are also sporadic, and they're also not large enough for depolarization for the whole entire fiber. So therefore, the only area that is getting any action through this process is the area directly underneath that motor end plate. And so that area is able to begin contracting due to the end plate potentials, but it will eventually lock up in a super contracted state. And so it's like those sarcomeres kind of get stuck together because of just the small continuous contraction that area is going through. And so as you can imagine, this will eventually produce a knot or a hypersensitive area within that fiber or bundle of fibers that are continuously going through those small sporadic contractions. So this is just a picture of the fibers, and so as you can see, the area where they would be locked is the area that is larger in diameter. So that is one way people have been able to microscopically tell the difference between those hypersensitive trigger point areas versus the rest of the fibers around that area. And so those will have the larger diameter and will be the ones that are hypersensitive. So basically, overall, the points of this section is that the lack of blood flow due to the sustained contraction or the repetitive contractions, or even the muscle damage or injury, will eventually lead to a lack of appropriate ATP. We are not getting enough energy for that stress tissue due to the blood vessels being compressed or being restricted in some way. And this will eventually lead to a sporadic small bursts of acetylcholine. And that will make the area underneath the motor end plate lock up, and that creates tension and pain. And so from therapy perspective, applying that gentle pressure over the area actually will mechanically stretch the fibers or unlock them, as I could say, in a different sense, and that us doing it ourselves over a hypersensitive area saves ATP. So it kind of breaks that energy crisis where normally we would need to have enough ATP regenerated to get those fibers working again. So you've gotten a little bit of background on the physiological process of how trigger points are formed. And so let's look into more of the causes or the types of trigger points. So there's two actual types of trigger points, active trigger points and latent trigger points. So active ones, they cause clinical pain. So the pain, the patient knows that there's pain. That was kind of an interesting way for me to put that. Which means that area is always tender and painful, especially during the physical compression of that area. So whether or not that area is being compressed or pressed on versus when it's not, it's always painful. These often restrict full range of motion, They kind of initiate muscle weakness, and then they also mediate local twitches when that fiber is stimulated. So latent trigger points are painful as well, but only when they are compressed. So when they are not being worked on, when nobody has touched that area or dug their fingers into that area, they are not typically painful. They are always found within a taut band of muscle. That would be the easiest way to find them because they are not painful until you actually press around. And then they also restrict full range of motion, or can, and then they also can produce muscle weakness. So the main three causes of the trigger points have to do with the surrounding muscle contraction. So the first type of contraction I want to talk about is sustained low-level muscle contractions. These are small contractions that can increase the pressure inside that area of muscle, leading to impaired blood flow. And remember what I talked about earlier, impaired blood flow is not good. We're not getting the right nutrients and oxygen that we need for that area to properly work. So each muscle, though, can handle different capacities of these sustained low-level muscle contractions. There's been a study done where it shows the percentages of what the upper trapezius can handle when it comes to contraction force versus the one of the quadricep muscles versus the soleus. So there's different percentages or levels of how these muscles can handle these contractions. The next one is maximal or submaximal muscle contractions. As you can imagine, this incorporates a high amount of energy, or ATP, that's needed to sustain these contractions. If the contractions force is high enough, the demands of the exercise or the activity will exceed the ability of the muscle cells to generate enough ATP. So the contraction is so hard or so large that the muscle is finally like, I don't have enough ATP left to actually sustain this hard of a contraction. And then eventually the area will run out of ATP, and then that leads to the sustained fiber contraction, ultimately leading to the trigger point formation. And then lastly, eccentric contractions. There's actually not as much research performed that says that these types of contractions truly do cause trigger points, but there's been a little bit of microscopic research pointing towards enlarged fibers after muscles have performed eccentric contractions. And like I said before, those enlarged fibers, when they're larger in diameter, that often points to a hypersensitive area or the trigger point. So overall, the muscle needs constant normal blood flow, and the blood flow brings the proper nutrients needed for the proper contraction of the fibers. So with all these contractions, at some point, blood flow is restricted in some way, and therefore that compromises the full potential. So now we've done the physiological aspect, kind of like the causes of trigger point formation, and now we're kind of going into more of a treatment aspect. So the first thing to talk about is soft tissue release. So soft tissue release can be done on pretty much anyone. So anyone involved with sports or exercise, went through a musculoskeletal injury, utilizes static posture a lot. So this is more geared towards like office workers or drivers, have inflammatory issues within the muscles or the fascia. So for example, plantar fasciitis, scar tissue that is restricting in some way, and then of course trigger points. So soft tissue is a type of treatment that is also used on trigger points, but for the most part, the benefits in general are that it increases blood flow, it releases tension and decreases muscle spasms. So as you can imagine, it's used on general tightness of the muscle as well. It can improve range of motion and flexibility, and then it can overall improve healing time. And I made those arrows between blood flow and healing time because blood flow brings the proper nutrients needed to help heal that area. And so if something can increase the blood flow to the area, the theory is that it will also improve the healing time. So with soft tissue release, there are three basic types. Passive soft tissue release is when the clinician locks a certain area of the muscle in place while the muscle is shortened, and then the clinician also, as they have the locking mechanism in place on the muscle, they move that muscle into a stretch themselves as well. So the clinician is doing it the whole time. This is pretty beneficial when you need the patient to be relaxed the whole time. And it's beneficial for the patient because they don't need to be educated on how to do this. They could just lay there, relax, and somebody does it for them. And then the next one is, I'm actually going to skip to active at the end and then go back to active assisted. I couldn't find a picture that was that portrayed active soft tissue release in a really good way for some reason, so that's why it doesn't have a picture. But as you can imagine, this is the complete opposite. So the patient is able to perform the whole thing. So they produce the locking mechanism on a certain area of the muscle, and they stretch that muscle themselves, or they go into an active range of motion to put that muscle in a stretch. Sometimes, though, the patient may not necessarily feel a good enough stretch when they have to do it themselves. And they also need proper education in order to be able to do a soft tissue release on themselves. And so going off the point that they may not always feel a stretch on their own, we move into active assisted. So this is kind of like the best of both worlds in some way. The clinician applies a locking mechanism, and the patient is the one that's actively stretching the muscle. This is nice because it's beneficial to the patient if they are unable to relax. And so they have the clinician working with them and encouraging them, or opposite of the active soft tissue release, if the patient doesn't feel a stretch with the active, they do the active assisted because the clinician is able to really put a lot of force behind that locking mechanism because they don't actually have to perform the stretch. So if the clinician can concentrate on the locking mechanism, they can make it deeper, and then therefore when the patient does move into a stretch, the patient will be able to feel it a little bit better. So soft tissue release is one general treatment that's not just used on trigger points, but can be beneficial for those tight, tense areas. But then there's a study done that compares manual therapy and dry needling for trigger points in patients that have mechanical chronic neck pain. And so there were several outcomes that they wanted to assess. The primary ones were neck pain, and they assessed that on a 0 to 10 scale. And then they wanted to assess general disability using the Northwick Park Neck Pain Questionnaire. They also wanted to have secondary outcomes that assessed pressure pain threshold, and they performed that over the C7 spinous process. And then they also wanted to assess cervical range of motion. So these primary and secondary outcomes were all assessed at a baseline, and then they were assessed immediately post-intervention, and then 1 week post-intervention and 2 weeks post-intervention. So the 2 weeks was kind of like the final measurement. And so they compared it across pre-intervention to 2 weeks after. So the actual treatments were, it was kind of a randomized control. So these participants the group was split in half, and one half got dry needling and the other half got manual therapy. So the ones that got dry needling applied, the dry needling was applied to trigger points in the upper traps. So when the needle was inserted, it was looking for a twitch response from that point. And when they were able to see a twitch response, they kind of moved the needle in and out about, not very far. I think it was about 2 to 3 centimeters, I believe, or millimeters. I'm sorry, I don't really quite remember, but it wasn't very far. They just moved the needle in and out of that area a little bit, and then they obviously took the needle out. So the dry needling was done within 2 sessions, one right after baseline testing and then one a week after that. Manual therapy was also had 2 sessions done in the same time aspect. So manual therapy consisted of several things. The first thing was a pressure release technique on the trigger points, like I previously talked about. Pressure often mechanically, the theory is that it mechanically unlocks the fibers without having to use ATP. And so this technique was done on the trigger points and the upper traps as well. And then the pressure varied, so the hopes was that the pressure grew stronger, and they applied 3 types of pressure for each point. And then the second thing that they performed was a stretching technique of the taut muscle bands, which is when basically you grab the band between both hands, in between your thumb and forefingers, pretty much, and then you stretch it out. So you physically stretch the band out by pulling your hands apart from each other. This was assisted with a passive stretch of the upper trap in general. And so, like I said, this manual therapy combination was also done right after baseline and a week after that. So overall, both groups significantly improved in pain and disability post-intervention, and then as well as the 1-week follow-up and the 2-week follow-up. However, dry needling did have greater improvements with the pressure pain sensitivity, so that threshold that was performed over the C7 spinous process. However, in general, I believe that both treatments can be successful options for trigger points, but to keep in mind that the study only looked at short-term effects, and so long-term effects are unknown. And then to make sure that you always rule out other variables that could be affecting the improvements that you may see. So the study did not have a control group. It only had 2 treatment groups. And so there may have been other variables within that patient's life outside of that treatment that could have affected these outcomes. Thank you so much for listening.